So tonight we are delighted to have Jill Ramsey as our speaker. She is the Behavioral Health Training Coordinator for the College of Health at the University of Alaska Anchorage. She holds a master's degree in psychiatric rehabilitation from Rutgers University, and she's been in the behavioral health field for 27 years. She is from New Mexico, but she has been in Alaska for 17 years, which I think makes her scuba. So please help me welcome Jill.
Thanks. That made me sound really, really old. So I started when I was 4 in my career. No, it just sounds like a lot. Thanks for being here. This is fun for me. And a great big topic to cover in an hour. So I think it's important, though, to kind of start with thinking about the history, thinking about where we've been with mental health treatment, our understanding of it, what mental health issues are, and sort of maybe attend to some of the reasons that you came here tonight, and hope that we get to that. So I wanted to do that, kind of go through the presentation. I have a video at the end I'd like to show of a personal story, and then maybe some discussion time. So if that sounds good, we'll do that. So just for the purposes of discussion, when we talk about a mental health disorder, we're talking about something that is different than the everyday experience. Different than our typical sadness when we have a loss, or anxiety when we're public speaking. It's something that interferes with our quality of life. That's how the diagnostic criteria is far more complicated than that, but we don't need to go there for our purposes tonight. But just to make a distinction of what we mean by a disorder. A disorder is something that has caused disorder. So it's something that has interfered with functioning and quality of life. But when we look at how mental health issues have been viewed over time, it begins, what we know of, begins with something spiritual. Demon possession, having been possessed by some sort of spirit or some sort of energy, some sort of entity. So treatments then followed what we would need to do about that to get rid of those spirits. And prehistoric times, that's where we were. Ancient Greece, it was really Hippocrates, our father of medicine, who first tried to address mental health issues in a different way, to see it outside of a spiritual crisis or a demon possession, and to step away from the superstitious beliefs and treatments and into something that he had formulated as the 4 essential fluids were responsible for mental illness: blood, phlegm, bile, and black bile. So again, the treatments followed the theory. If the problem's with the blood, then we're going to do bloodletting. If the problem is bile, we're going to induce vomiting. There was all sorts of ways to get at these theories, these ideas of what was wrong and how to address it. We then had the Middle Ages, which not much changed. We had the Renaissance era, which brought other considerations and theories, like maybe this wasn't, maybe those theories weren't completely right. Maybe what people needed was to have their senses shut down. We started doing things like sensory deprivation, keeping people in these cribs, they call them, where people couldn't move. Maybe we had to restrict movement. All sorts of history around how we got here, how we came to think of mental health issues the way that we have. If you think about all of that history and all of those treatments, and you kind of begin to see where the stigma started in the first place. We didn't think well of people who had mental illness. We didn't understand it. So moving on into 17th and 18th century, things didn't get a whole lot better. We were still opening the skull to let spirits out, opening body parts to let fluids out. We were still doing some exorcisms of the demons, and on and on and on. This is the guy I blame the most for some of the stigma that has been perpetuated since. René Descartes. So he was the first philosopher to really separate the head from the body in the theories. Of course, everybody back then was a philosopher and a scientist, right? Because nobody had proven anything. So to separate the head from the body, what that meant was that we thought about ailments differently. And if you think about that, it's happened ever since. We have set up treatment that way. We've set up insurance payment that way. We have completely separated the head off the body. Instead of the holistic way that we probably should have been thinking about that. So, yeah, I'm kind of mad at him. But even with that theory, we continued to try some of these other things. Mostly, institutions were set up in the 17th century to protect society from people with mental illness. Not to treat them. To protect society from these things we didn't understand. We were still bleeding people out. We were using leeches for all kinds of things, including mental illness. And we were still doing weird psychosurgery things to the skull. We began to warehouse people because it wasn't working. These treatments weren't really working very well. And we even began more warehousing of people in order to protect society from them. So fast forward, we know that there were revolutionary times with Dorothea Dix, who came into institutions and found horrible conditions, made some changes during the civil rights, first civil rights push early on. But you know, it was only 1949, which is not that long ago, and put in perspective, that we gave someone a Nobel Prize for the lobotomy. Everybody know what the lobotomy was? It's an ice pick, right? Through the occipital opening and a frontal lobe sweep, which calmed people right down. They stopped acting weird. So, if you were born in the 20s, 30s, 40s, what might your perception of getting mental health treatment look like? Who's signing up for that? Right? So we have all kinds of ways in which that we've gotten to this place where stigma is what it is. Interestingly enough, there are still societies that believe in demon possession, that this is what the symptoms are representing. There are still some people that believe in supernatural powers. Masturbation was a huge theory. Does anybody know the history of cornflakes? That's a weird thing to put together, wasn't it? Mm-hmm. It is a weird thing to put together. John Kellogg was the superintendent of an insane asylum in Michigan when he came up with a theory that a lot of ailments, including mental illness, were caused by masturbation. So he decided that what people needed, I'll just tell you. 39 different symptoms of a person plagued by masturbation included general infirmity, defective development, mood swings, fickleness, bashfulness, boldness, bad posture, stiff joints, fondness for spicy foods, acne, palpitations, and epilepsy. Holy crap. So he decided that it was all about the diet, and that meat increased sexual desire, and that we needed plain, boring food that wouldn't stimulate anything dangerous. This man came up with what you know today to be granola. He took really plain, he came up with some other things that didn't stick, and you're going to be glad that they didn't. He came up with the granola as the worst imaginable kind of stuff at first, but it became granola. He also came up with cornflakes, what we know today to be cornflakes. This was all in preparation for feeding these inmates something that wouldn't cause them to want to masturbate, which was causing their mental illness to begin with. You're never going to look at cornflakes the same way. I'm pretty sure. He also came up with this enema idea with yogurt. So you would ingest half of the yogurt by mouth and the other half as an enema, and that was one of the treatments too. That was one of the things that didn't stick. So we're all very glad of that. So some really very strange things have happened in order to address mental health issues and theories that were acted on that we know to be really, really wrong. Cornflakes may be good for you. I don't know if it has all the other benefits that were intended, but we have that. We've had theories about different drugs causing mental illness, and that was the only cause. We know that that's not true. Bad parenting. What a huge theory with Freudian theory, Erikson theory, a whole lot of early theorists who talked about the schizophrenogenic mother, the mother who gave double messages. They called it the double bind. So if you got mixed messages as a child, you went on to develop schizophrenia. Bad parenting caused psychotic episodes, which has been disproven again and again and again. Bad parenting causes some unpleasant things. Schizophrenia is not one of them. Environmental toxins, we thought about lead-based paint caused mental illness, all sorts of theories about that. We talked about willpower, if people were choosing this volitionally, and we still talk about whether people are ill because they're non-compliant with their treatment or if the treatment isn't working. We're still battling that out, right? Western medicine. So when psychiatry was developed, it actually was a split from neurology. So if you think about what that might have implicated, it meant that some of these disorders that were originally thought of as neurological brain disorders were now housed under psychiatry and treated very differently than they would have been if we still considered them brain disorders. Now we have character disorders and we have all kinds of other things. We have all kinds of stigma around things that are really biologically based brain disorders. So we have that history to contend with too. I wonder what would have happened if that had all stayed under neurology. If we could have continued to think about brain disorders as brain disorders and not some of the other things that we've called that. So the medical model of Western medicine has brought some really pretty horrible terminology along with it as well. We have chronic, we have gravely disabled, which is part of our criteria for receiving help. You have to be gravely disabled or dangerous. Where else in healthcare do we do that? We made a criteria out of that. We have words like refractory and difficult to treat. I started in the mental health field that became the dual diagnosis field, which became the co-occurring disorders field, which eventually became behavioral health because they gave up trying to figure out how many disorders people had at once. Honestly, I wish we had stuck with the brain disorders field because that's really more accurate for what we're addressing. So the terminology matters a lot. The terminology drives the stigma and is part of how we perpetuate these kinds of false notions by the way that we talk about things. Severe and persistent mental illness, that's That's been the SPMI acronym that people in the field have been using. Severe and persistent mental illness, which is not very descriptive at all. Kind of identifies the helplessness and frustration of the provider, maybe, if you consider something severe and persistent. Sounds more like a yeast infection than it does a brain disorder, but it lets you know the provider's frustrated with it, doesn't it? So our treatment has made advances, but there are still challenges, right? We have a very medically based, pharmacologically driven approach that's not always successful, and often the side effects of the medication outweigh the benefits of the medication. Some of the medications are great. Some of them work really well and have saved people's lives and do so every day. And I have people tell me how their life was saved and improved by that medication. Others don't respond as well. Stigma permeates everything. You can see it in the research dollars. If you look at the amount of money spent on other issues, other ailments, you can see the disparity in healthcare coverage. You see the disparity in even what we pay people who work in mental health versus other parts of healthcare. The stigma is there. So hey, you'll forget what you even came in for after we give you these medications and these side effects. Other kinds of healthcare and other kinds of cultural perspectives have always included a more holistic approach. Haven't forgotten the spiritual aspects of wellness, of healing. It's kind of cutting edge now that the new thing in psychiatry is to think holistically. It's not paid for by insurance, but it's the new way to think about things, as if we have totally forgotten that the head's attached to the body. So in our modern treatments, we've got a few options. Hospitalization. We still do electric shock therapy. It's controlled, it's done differently, but it's still there. Other parts of the world are doing some very targeted brain stimulation with some pretty good results. There's a treatment in Europe that's available for people with bipolar disorder with great success that can stimulate one particular part of the brain in a very precise place and will stop a manic episode in its tracks. It comes back. They haven't perfected it a way to permanently change that, but there are advances the more that we learn about the brain. Our pharmacology is changing, but it isn't there yet. Talk therapy, group therapy, cognitive therapy. There's no one treatment for mental illness because there's no one cause. Mental illness is caused by a combination of factors, and what we know about best practices now is that it takes a combination of therapies. The most successful thing that we know of, turns out, isn't medication at all. It's support. Support comes in the form of a safe place to live, a purpose in life, a job to do, a relationship to count on, a soft place to land, a social structure, all the things that we all need. Turns out that's the best practice for treating mental illness. So in psychosocial rehab, we provide supported employment, ways for people to be successful and have purpose. We provide housing so that people have a safe place to recover. Provide daily living skills if people have lost that. Socialization, clubhouses, places to belong, peer support. Walking that journey with somebody who's been there, done that, and recovered is a hugely powerful, one of the most effective things that we've ever known for mental illness. So causes are complex. Turns out it's not demon possession. It's not masturbation. It's a combination of things when occurring at once creates the disorder. There are genetic factors. Trauma plays a huge role in a lot of disorders, like depression and anxiety and substance use disorders. Brain chemistry. Brain chemistry is changed by trauma. Brain chemistry is changed by depression. And that's the way we think of it, so that's the way we treat it. But if we do one of those things and not all of the other things, it really falls apart. We now know there are disorders of personality, they call them, where people learn maladaptive ways of moving through life because of what has happened to them, because of how they've experienced childhood. Adjustment disorders. We all kind of are individually equipped in different ways with different coping in order to manage things. And of course, brain injury can certainly be a cause of some symptoms of mental health issues. But what if we treated it differently? What if we thought about it differently? Or what if we treated the medical issues the way that we treat mental health issues? Would anybody stand for that? Probably not. So here's somebody's bleeding out of, his stomach. It's like you're not even trying, right? These are some of the things that we tell people who are struggling with mental health issues. Well, if you would just do what the doctor told you to, if you would just exercise, or if you would just, and we don't really understand that they haven't chosen this. Well, lying in bed obviously isn't helping you any. Sort of the bootstraps theory. So it's something to think about in terms of how we think about people with mental illness and whether or not they have chosen where they are. And the stigma that surrounds that is demonstrated by our language and how we treat one another. If you think about all the labels that you've ever heard for when somebody means to say someone with a mental health issue, but they say what?
Crazy.
Crazy. What else? Nuts. Maybe Psycho. It gets worse than that, and you're all being very polite because you're on camera, right? But the reality is we have normalized this way of talking about people. Our society has normalized talking in a derogatory way about an entire group of people who are suffering from a brain disorder, and we don't even realize that, most of us. But pay attention sometime to how many times a day you say that's crazy. That's nuts. Or if you're using language that is derogatory, imagine the effect that might have on someone next to you who may be struggling, thinking about getting help. How does that affect whether or not they go? This is something that we can do individually too to combat stigma. We can't change the world, but we can control what comes out of us, right? And how we treat people. Think about, and I have people do this in training and in other exercises, what if we made a list of all the racial slurs you've ever heard in your life? Now, none of you are going to say a word, right? Because that's a really uncomfortable topic. We don't allow those things to come out of our mouth. We don't associate with people who speak that way and say those things. People with mental illness are no different. It's not any different. It's completely unacceptable to use those kinds of terms when what we mean is someone who's experiencing. I've been corrected a number of times by a good friend who has schizophrenia who says, I don't suffer. Stop calling me someone who suffers from schizophrenia. I don't suffer. I'm having a great time. Because he's treated, and he's doing really, really well. So I've trained myself to say someone who's experiencing whatever that is. The most important part of that is that we talk about the someone first. There are no schizophrenics. There are no bipolars. There are no autistics. There are only people. Only people who happen to be experiencing a disorder of whatever kind. So once we change that language, we make that flip, we begin to show respect in how we communicate. And it's really, really important to do. It seems like a fine point, but it isn't trivial to somebody who you may not know what they're dealing with. We never know what everybody's dealing with. So it's something to think about. What you hear, what you say, what's it mean, how does it impact other people? How do we talk about mental illness appropriately then? How would you describe mental illness to a child? What are the words you would say? Think about that sometime when you're communicating about that, or if you're communicating about that. How would you explain that? You wouldn't say, well, that person's nuts. Would you? Please? You don't? You might explain that person, may have an illness that affects their brain. Like, other organs of your body can become sick. Sometimes the brain has problems. But it's treatable, just like some of the other things. The impact of stigma is incredible. We may not realize, unless you're personally affected, family's affected, you may not have experienced this, you may not see it, it may be invisible to you. But the impact of stigma is huge. Talking about relationships, think about all the things that are most important to you in your life. Just hold that in your mind. What are the 5 most important things in my entire life? And take away about 4 of those. Stigma will do that. Stigma can remove your sense of security, your dignity, your housing, your career. Not the mental illness necessarily, certainly the stigma. We know that a large number of people recover. We know that in academia. We know that in providing services. The general community probably doesn't. It's not safe to tell you. If I've recovered from schizophrenia, I'm probably not going to share that with you, because you're probably going to question everything that comes out of my mouth afterwards, right? It's not. We still don't live in a world where it's safe for people to share their story who have recovered, which is unfortunate, because we need that hope. We need to know that that's possible, and we need to have that inspiration for other people, and we encourage people to talk about it. We need safe places to talk about it and to encourage that to happen, because it does. And I'm gonna show you a story in a minute. And the story is of Ellen Sachs. Now, Ellen Sachs is a law professor at UCLA. She's also someone who has battled with schizophrenia her whole life. Are all of you TED Talkers? You like the TED Talks? Yeah. So you may have seen it. Even if you have, it's worth seeing again. So we're going to let Ellen tell her story and then have some discussion. Oh, no, we're not doing it on there, are we? We're doing it on there. I think it's queued up. I won't stop it, will it?
So I'm a woman with chronic schizophrenia. I've spent hundreds of days in psychiatric hospitals. I might have ended up spending most of my life on the back ward of a hospital, but that isn't how my life turned out. In fact, I've managed to stay clear of hospitals for almost 3 decades, perhaps my proudest accomplishment. That's not to say that I've remained clear of all psychiatric struggles. After I graduated from the Yale Law School and got my first law job, my New Haven analyst, Dr. White, announced to me that he was going to close his practice in 3 months, several years before I had planned to leave New Haven. White had been enormously helpful to me, and the thought of his leaving shattered me. My best friend, Steve, sensing that something was terribly wrong, flew out to New Haven to be with me. Now I'm going to quote from some of my writings. I opened the door to my studio apartment. Steve would later tell me that for all the times he had seen me psychotic, nothing could have prepared him for what he saw that day. For a week or more, I had barely eaten. I was gaunt. I walked as though my legs were wooden. My face looked and felt like a mask. I had closed all the curtains in the apartment, so in the middle of the day, the apartment was in near total darkness. The air was fetid, the room a shambles. Steve, both a lawyer and a psychologist, has treated many patients with severe mental illness, and to this day he'll say I was as bad as any he had ever seen. Hi, I said, and then I returned to the couch where I sat in silence for several moments. Thank you for coming, Steve. Crumbling world, word, voice. Tell the clocks to stop. Time has come. White is leaving, Steve said somberly. I'm being pushed into a grave. The situation is grave, I moan. Gravity is pulling me down. I'm scared. Tell them to get away. As a young woman, I was in a psychiatric hospital on 3 different occasions for lengthy periods. My doctors diagnosed me with chronic schizophrenia and gave me a prognosis of, quote, grave. That is, at best, I was expected to live in a board and care and work at menial jobs. Fortunately, I did not actually enact that grave prognosis. Instead, I'm a chaired professor of law, psychology, and psychiatry at the USC Gould School of Law. I have many close friends, and I have a beloved husband, Will, who's here with us today. Thank you. He's definitely the star of my show. I'd like to share with you how that happened and also describe my experience of being psychotic. I hasten to add that it's my experience because everyone becomes psychotic in his or her own way. Let's start with the definition of schizophrenia. Schizophrenia is a brain disease. Its defining feature is psychosis or being out of touch with reality. Delusions and hallucinations are hallmarks of the illness. Delusions are fixed and false beliefs that aren't responsive to evidence, and hallucinations are false sensory experiences. For example, when I'm a psychotic, I often have the delusion that I've killed hundreds of thousands of people with my thoughts. I sometimes have the idea that nuclear explosions are about to be set off in my brain. Occasionally I have hallucinations, like one time I turned around and saw a man with a raised knife. Imagine having a nightmare while you're awake. Often, speech and thinking become disorganized to the point of incoherence. Loose associations involves putting together words that may sound a lot alike but don't make sense. And if the words get jumbled up enough, it's called word salad. Contrary to what many people think, schizophrenia is not the same as multiple personality disorder or split personality. The schizophrenic mind is not split, but shattered. Everyone has seen a street person, unkempt, probably ill-fed, standing outside of an office building, muttering to himself or shouting. This person is likely to have some form of schizophrenia. But schizophrenia presents itself across a wide array of socioeconomic status, and there are people with the illness who are full-time professionals with major responsibilities. Several years ago, I decided to write down my experiences and my personal journey, and I want to share some more of that story with you today to convey the inside view. So the following episode happened the 7th week of my first semester of my first year at Yale Law School, quoting from my writings. My 2 classmates, Rebel and Val, and I had made the date to meet in the law school library on Friday night to work on our memo assignment together, but we didn't get far before I was talking in ways that made no sense. Memos are visitations, I informed them. They make certain points. The point is on your head. Pat used to say that. Have you killed anyone? Rebel and Val looked at me as if they or I had been splashed in the face with cold water. What are you talking about, Ellen? Oh, you know, the usual. Who's what, what's who, heaven and hell. Let's go out on the roof. It's a flat surface. It's safe. Rebel and Val followed, and they asked what had gotten into me. This is the real me, I announced, waving my arms above my head. And then, late on a Friday night, on the roof of the Yale Law School, I began to sing, and not quietly either. Come to the Florida sunshine bush. Do you want to dance? Are you on drugs, one asked. Are you high? High, me? No way, no drugs. Come to the Florida sunshine bush, where there are lemons, where they make demons. You're frightening me, one of them said, and Rebel and Val headed back into the library. I shrugged and followed them. Back inside, I asked my classmates if they were having the same experience of words jumping around our cases as I was. I think someone's infiltrated my copies of the cases, I've said. We've got a case to joint. I don't believe in joints, but they do hold your body together. It's an example of loose associations. Eventually, I made my way back to my dorm room. And once there, I couldn't settle down. My head was too full of noise, too full of orange trees and law memos I could not write and mass murders I knew I would be responsible for. Sitting on my bed, I rocked back and forth, moaning in fear and isolation. This episode led to my first hospitalization in America. I had 2 earlier in England, continuing with the write-ins. The next morning, I went to my professor's office to ask for an extension on the memo assignment, and I began gibbering unintelligibly as I had the night before, and he eventually brought me to the emergency room. Once there, someone I'll just call the doctor, and his whole team of goons swooped down, lifted me high into the air, and slammed me down on a metal bed with such force that I saw stars. Then they strapped my legs and arms to the metal bed with thick leather straps. A sound came out of my mouth that I'd never heard before. Half groan, half scream, barely human, and pure terror. Then the sound came again, forced from somewhere deep inside my belly and scraping my throat raw. This incident resulted in my involuntary hospitalization. One of the reasons the doctors gave for hospitalizing me against my will was that I was, quote, gravely disabled. To support this view, they wrote in my chart that I was unable to do my Yale Law School homework. I wondered what that meant about much of the rest of New Haven. During the next year, I would spend 5 months in a psychiatric hospital. At times, I spent up to 20 hours in mechanical restraints. Arms and legs tied down, arms and legs tied down with a net tightly across my chest. I never struck anyone, I never harmed anyone, I never made any direct threats. If you've never been restrained yourself, you may have a benign image of the experience. There's nothing benign about it. Every week in the United States, it's been estimated that 1 to 3 people die in restraints. They strangle, they aspirate their vomit, they suffocate, they have a heart attack. It's unclear whether using mechanical restraints is actually saving lives or costing lives. While I was preparing to write my student note for the Yale Law Journal on mechanical restraints, I consulted an eminent law professor who was also a psychiatrist and said surely he would agree that restraints must be degrading, painful, and frightening. He looked at me in a knowing way and said, "Ellen, you don't really understand. These people are psychotic. They're different from me and you. They wouldn't experience restraints as we would." I didn't have the courage to tell him in that moment that no, we're not that different from him. We don't like to be strapped down to a bed and left to suffer for hours any more than he would. In fact, until very recently, and I'm sure some people still hold it, is the view that restraints help psychiatric patients feel safe. I've never met a psychiatric patient who agreed with that view. Today, I'd like to say I'm very pro-psychiatry, but very anti-force. I don't think force is effective as treatment, and I think using force is a terrible thing to do to another person with a terrible illness. Eventually, I came to Los Angeles to teach at the University of Southern California Law School. For years, I had resisted medication, making many, many efforts to get off. I felt that if I could manage without medication, I could prove that, after all, I wasn't really mentally ill. It was some terrible mistake. My motto was the less medicine, the less effective. My LA analyst, Dr. Kaplan, was urging me just to stay on medication and get on with my life, but I decided I wanted to make one last college try to get off, quoting from the text. I started the reduction of my meds, and within a short time, I began feeling the effects. After returning from a trip to Oxford, I marched into Kaplan's office, headed straight for the corner, crouched down, covered my face, and began shaking. All around me, I sensed evil beings poised with daggers. They'd slice me up in thin slices or make me swallow hot coals. Kaplan would later describe me as, quote, writhing in agony. Even in this state, what he accurately described as acutely and floridly psychotic, I refused to take more medication. The mission is not yet complete. Immediately after the appointment with Kaplan, I went to see Dr. Martyr, a schizophrenia expert who was following me for medication side effects. He was under the impression that I had a mild psychotic illness. Once in his office, I sat on his couch, folded over, and began muttering. Head explosions and people trying to kill. Is it okay if I totally trash your office? You need to leave if you think you're going to do that, said Martyr. Okay, small, fire on ice. Tell them not to kill me. Tell them not to kill me. What have I done wrong? Hundreds of thousands with thoughts, interdiction. Ellen, do you feel like you're dangerous to yourself or others? I think you need to be in the hospital. I could get you admitted right away and the whole thing could be very discreet. Ha ha ha. You're offering to put me in hospitals? Hospitals are bad, they're mad, they're sad. One must stay away. I'm God, or I used to be. At that point in the text where I said I'm God, or I used to be, my husband made a marginal note. He said, did you quit or were you fired? I give life and I take it away. Forgive me for I know not what I do. Eventually, I broke down in front of friends and everybody convinced me to take more medication. I could no longer deny the truth and I could not change it. The wall that kept me, Ellen, Professor Sachs, separate from that insane woman hospitalized years past, lay smashed in her rooms. Everything about this illness says I shouldn't be here, but I am. And I am, I think, for 3 reasons. First, I've had excellent treatment. 4 to 5 day a week psychoanalytic psychotherapy for decades and continuing, and excellent psychopharmacology. Second, I have many close family members and friends who know me and know my illness. These relationships have given my life a meaning and a depth, and they also help me navigate my life in the face of symptoms. Third, I work at an enormously supportive workplace at USC Law School. This is a place that not only accommodates my needs, but actually embraces them. It's also a very intellectually stimulating place, and occupying my mind with complex problems has been my best and most powerful and most reliable defense against my mental illness. Even with all that, excellent treatment, wonderful family and friends, supportive work environment, I did not make my illness public until relatively late in life. And that's because the stigma against mental illness is so powerful that I didn't feel safe when people know it. If you hear nothing else today, please hear this. There are not schizophrenics. There are people with schizophrenia. And these people may be your spouse, they may be your child, may be your neighbor, they may be your friend, they may be your coworker. So let me share some final thoughts. We need to invest more resources into research and treatment of mental illness. The better we understand these illnesses, the better the treatments we can provide, and the better the treatments we can provide, the more we can offer people care and not have to use force. Also, we must stop criminalizing mental illness. It's a national tragedy and scandal that the LA County Jail is the biggest psychiatric facility in the United States. American prisons and jails are filled with people who suffer from severe mental illness, and many of them are there because they never received adequate treatment. I could have easily ended up there or on the streets myself. A message to the entertainment industry and to the press. On the whole, you've done a wonderful job fighting stigma and prejudice of many kinds. Please continue to let us see characters in your movies, your plays, your columns who suffer with severe mental illness. Portray them sympathetically and portray them in all the richness and depth of their experience as people and not as diagnoses. Recently, a friend posed a question. If there were a pill I could take that would instantly cure me, would I take it? The poet Rainer Maria Rilke was offered psychoanalysis. He declined, saying, don't take my devils away because my angels may flee too. My psychosis, on the other hand, is a waking nightmare in which my devils are so terrifying that all my angels have already fled. So would I take the pill in an instant? That said, I don't wish to be seen as regretting the life I could have had if I'd not been mentally ill, nor am I asking anyone for their pity. What I rather wish to say is that the humanity we all share is more important than the mental illness we may not. What those of us who suffer with mental illness want is what everybody wants. In the words of Sigmund Freud, to work and to love. Thank you. Thank you. Thank you. Very kind. Thank you. Thank you.
Okay, so you've met Ellen. Ellen's one of many, 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 many people who've recovered and is one of the few brave enough to talk about it. So I wanted you to see that because I want you to know that. I want you to have the experience of her story. She wrote a wonderful book called The Sinner Will Not Hold about her experience. She's written a couple of books, but that's really the one of her journey and all of the, it's kind of a historical perspective of the treatment of mental illness when you think of the decades that it spans and the treatment that she got, and from then to now, it is truly, remarkable what she's been through. It shows you also the resilience of people who are struggling. So with that, have we got questions or discussion things that you want to talk about, things that you want to ask, or reactions to Ellen Sachs? You're all looking a little depressed,
No.
That's supposed to be an inspiring video. Yes, sir.
With the new president coming on board,
Oh my gosh.
do you feel like it may be helpful? His ability or his ways?
I have no idea where our president-elect is on the treatment of mental illness. I know that there's been some traction made in the last administration with some efforts for improved mental health care and some infusion of money to states to provide that. I really couldn't say. I think we have to stay diligent in our advocacy efforts for parity and for best
what I was
practices
just
in
gonna
Alaska. Yes.
No, that was what I was going to say. That was one of the basic tenets of the Affordable Care Act was parity.
Right.
Never came to fruition.
So, and that's been a struggle ever since Rene Descartes, right? I still blame that guy for separating the head from the body, and our healthcare system has done that. Our insurance has done that. We still don't have parity. We're still not treating things in the same way. We've made leaps and bounds, and hopefully some of the historical perspective helps to see that. When we are feeling so frustrated, we can look back and see where we've been, but we certainly have a long way to go as well. And that takes individual commitment to our language. It takes advocacy for our families and ourselves to insist on good care. And
Personality disorders were referred to. What is meant by that?
personality disorders are they're symptoms that people have relative to mostly to some of the background that they've experienced that may have resulted in maladaptive coping mechanisms. There's a whole lot of different personality disorders that show up in different ways. They're really treated by long-term therapy. So, are there particular personality disorders that you're thinking of?
Well, yeah, I guess I was thinking of borderline personality disorder, narcissistic, but are they always caused by, or is it thought that they're always caused by something that happened in the person's life experience?
No, you can't generalize all personality disorders and their causes, and I didn't mean to do that, but borderline personality disorder oftentimes is related to difficult childhood. Not always, but it's has been associated with abuse.
Are personality disorders in general possibly something that are less understood than some of?
Absolutely.
Yeah.
And I think there are a lot less people willing to treat them because there's less known about how to do that. Some of that involves reparenting. It involves a really long process of going back through developmental phases that were interrupted by trauma, interrupted by abuse. Maybe a lot of them take a really long recovery journey that requires a commitment of the provider and the patient that doesn't often happen and isn't often paid for by insurance, right? We have an insurance system now where they're calling parity that gives you a set number of sessions and you're supposed to be done. And that's probably not reasonable for some people who are really, really struggling with severe personality disorder.
Have you ever been diagnosed with any type of mental illness?
I haven't. I probably meet a diagnostic criteria for seasonal affective disorder. I do experience some fairly serious depression in the fall time, and I self-diagnose quite a bit. Yes.
You seem to be in favor of peer support.
Absolutely.
Could you speak to that a little bit further?
Sure. So, peer support is, in my experience, has been one of the most powerful things that I have seen help somebody recover. So, the dynamic of having somebody like Ellen, or somebody who's had the lived experience of, not just a lived experience of mental illness, but the lived experience of recovery, help someone else take that journey, has been more powerful than the treatment they're getting from a psychiatrist. Because we're talking about all of the other things that takes. It's not any one thing. Medication may be important, the housing may be important, but having that support to help guide somebody and navigate the systems and all of the things that it means to be successful has been the most powerful and successful thing that we've ever seen. We just don't have enough people to do that. We don't have enough people willing to be outed about their mental health issue and become a peer support person, even though, it's. The last person I encouraged to do that told me, look, if you were in a car crash and you spent a lot of time in hospitals and you finally recovered and you were able to go back to work, would the first job you want, would it be helping people in car crashes? And I said, no, that's not my journey. So it's not everybody's wish to do that. And in fact, the stigma is such that most people want to be as far away from the mental health system as they can get once recovered. But those who fully embrace this idea, this understanding that these are brain disorders and they're treatable, people can recover and can come back and do peer support is truly invaluable. Yeah.
What would you suggest as a methodology for approaching stigma in the larger population in terms of ameliorating it?
In terms of?
Ameliorating stigma in society in general.
Well, it starts individually by our language, but I think that the more you know as a community. So one of the things that we've done is we've started mental health first aid trainings in as many places as we can do it. Now, mental health first aid is a course like standard first aid, only it teaches people to recognize signs and symptoms of mental health and substance abuse problems, and then a first aid strategy around what do I do about that? What are the appropriate things for me to say and do, and how would I help somebody? It also spends a great deal of time talking about stigma, talking about discrimination, talking about ways in which we can convey respect instead of kind of what's been normalized for us to do in the ways that we talk about mental health issues. So I think that's a big help too. Something for the layperson to get information, some way for people who, it's not like we all got that in health class, right? We didn't get this information. We often don't get this information unless we are personally dealing with it, or we have a family member who's dealing with it. Otherwise, there's just not a place where we can receive that as a community. So mental health first aid is one of those things. We just did that course today across the way. And I think it's changing. We see a lot more programming with accurate information than we ever have before. There's still some misinformation, certainly. But as a community, I think we share what we know. I often tell people in mental health first aid, if you liked this course, if you learned something, tell 5 people. If you didn't like it, just come tell me privately in the hallway. But we've never really had anybody say they didn't like it. Oftentimes people are really grateful to have that information. And what's heartbreaking is most people say, why didn't we have this 20 years ago? Where was this information when I needed it? or when my son was struggling, or why is it taking so long? I kind of think it's, you know, if you think about how long it's taken to get here, I think it's going to take a while to put the head back on the body. There was a lot of effort that went into separating things out. I think it's going to take a equal measure of work to put it back together.
It sort of feels like we're pioneers again.
Yes, yes, it's a new idea to integrate primary care and behavioral health. Wow, wow, the head really is attached. Yes.
For some reason I feel pressed upon to talk about the vulnerability of the mentally ill person. Because a mentally ill person is not only vulnerable to abuses from the society in general, from being misunderstood, but from the healthcare system itself. Because a person who's mentally ill doesn't know what reality is always, as part of the definition.
Mm-hmm.
And they're dependent on those around them to help them identify what reality is. They're dependent upon their doctors to prescribe medications and to help them know when they're experiencing normal experiences and abnormal experiences. And I just really, first of all, I caution people to be very careful not to add to the problems of those who are already very, very traumatized and very hurt by what's going on in their lives. Mm-hmm. And to, as much as they can, educate themselves, even if they're not directly responsible in someone's life. Like you say, part of the stigma has to be overcome by education.
Yes.
And knowing, any of us is vulnerable to becoming mentally ill under the right circumstances.
Absolutely. We're all on a spectrum. And this, I don't mean for this to sound like bad news, but there's no such thing as perfect mental health, right? We're all somewhere. But I think that we have to also be educated consumers of what's coming out in the media, know the difference between what's sensationalized and what's really happening, what's really a brain disorder, and what's fiction, what's a fictional horror character. We have that to contend with. We know that there's a misconception that people are violent, that people with mental illness are inherently violent. It's been disproven by study after study. What we know is that people are 11 times more likely to be victims of violent crime than the perpetrator of violent crime. But if you were just tuning into Facebook or
violent crimes against themselves.
Yes.
More likely to be a victim of self-injury of
Yes.
some sort than they are of
Right.
injuring somebody else.
The other thing that we can do is be educated consumers and advocates and insist on good care. And where you can go with a friend or have a friend go with you and say, look, tell me more about this medication. What is the cost benefit of this medication? What are the side effects I'm likely to experience? Where's my line of what's the cost, what's the benefit of each and every treatment that's prescribed? We're in a new era. A lot of, my parents are in their 70s, late 70s, and they will do anything the doctor says. It doesn't have to make sense. The doctor said do it, I'm going to do it. And we constantly have these conversations about, well, have you explained everything that you're feeling? We're coming to a place where we really have to stand up for ourselves, and we really have to have advocates. We really have to be asking really good questions about our treatment. Because we can't blindly, follow a recommendation for a very serious psychotropic medication that may have some really significant permanent side effects, right? We need to know that that's a good cost-benefit outcome. So the more we know, the more we can do that for ourselves and for the people that we love and care about, and be good consumers and be good advocates.
I agree with you on the doctor part. I'm just a kid, I'm only early 70s. But you're right, you have to ask questions.
Yes, and we're learning to do that, and they're learning to do that. But it's, there's some generational things that you just didn't question what the doctor said to do. Yes.
I was in an orphanage for 9 years. It's all troubled kids or whatever. The kids were there, we didn't all, but what I noticed was the kids would be doing this, that never stopped. It's like, what is that about? Could you say anything about that?
I really wouldn't know without
They'd
knowing
be
more
sitting
about
in the corner doing, just, and you look over here, it was interesting.
Yeah.
It's like watching
Something's
a movie,
going on there.
crazy movie or
It'd be
something.
hard to say.
But then after I got out of there, I went into the other world, where it was like a public school. This was a Catholic orphanage that I was in. But when I went to public school, boy, everybody was having a great time in the classroom. As soon as the teacher walked out, they was throwing the chalkboards and, throwing chairs out the window.
Sounds like an interesting
Yeah.
experience
It's
in your
Oklahoma.
life.
Oklahoma City.
So yeah, those you can think back of people in your life, and maybe that's what was going on for them. It's hard to say. It's hard to know now retrospectively about those things. We certainly know more than we used to. We're not drilling holes in your head to let the evil spirits out, and we're eating cornflakes for a completely different reason.
Do they still use insulin shock in the treatment?
No, they don't, but they did. They certainly did. There's this whole idea that shock will change somebody's mental status. So we did a lot of things to shock people. We dunked them in ice water. We did induced insulin shock, electric shock. I've had people ask me in mental health first aid, shouldn't we slap somebody having a panic attack?
Oh,
By the way, we don't recommend slapping anyone for any reason whatsoever. But the idea there is that's what they've seen on MASH. That was her explanation. Or Moonstruck, snap out of it. The idea is that if we can jolt somebody out of their state of mind, it'll change to a better state of mind. And you understand the theory behind that, but it's not effective.
If I start having a panic attack and somebody smacks me, I'm gonna smack them back.
Yes.
Get off
So
me.
now you have a bigger problem, right? You have a brawl. Yeah, so there's no slapping.
Do any of the alternative therapies show promise, like magnetic therapy or?
Some of them are, in other countries. And an alternative here means something different. In Europe, a standard part of healthcare, of mental health care, involves acupuncture, acupressure, massage, really looking at nutrition, looking at food allergies, looking at exercise. It's, but the new brain stimulation research is pretty interesting, because we've learned that it's not just the neurochemistry of the brain that we're dealing with. It's also the electric, the channels that open up and for different reasons. And you stimulate this part of the brain, then depression gets better. Or you stimulate this part of the brain, and it stops mania. So it's experimental, though. That's the tricky part of any of this, is that somebody has to sign up to test it. Yeah.
I was just going to say, Kathleen, I saw a wonderful documentary on, I think, Amazon Prime, just on some of these treatments that are being shown to be effective on all sorts of neuro challenges and things. So check it out. I can't remember what it was called, but it was on neuroplasticity. And they were just showed a variety of alternative medicines that are working.
Yeah, we heard about that from someone else.
Yeah. Anyway, it was great. It was really informational. So that had some options.
Yeah. Well, just on NPR the other day, they were talking about stimulating the brain with ultrasound for essential tremor. Stimulate the opposite side of the brain from the hand you have the tremor in. It was interesting. So,
there's brand new research about brain injury. We had always been told, there's nothing you can do there. Turns out the brain has elasticity. There is a window of time which, if treated with the right pharmacology following a brain injury, can restore full functioning. If you miss the window, then the likelihood of restoring that changes. So there's some new research that we didn't know before.
A good friend of ours was injured in Afghanistan. She was doing 30 to 40 seizures a day before they got a hold of her down in California. And she spent 2 years at a medical school. They did all kinds of emotional, mental exercises with her all day long. Took 2 years, brought her back. She's down to 1 seizure a year.
Woohoo, that's amazing.
Finished her EMT course.
So the brain is very complex. It's kind of our last frontier in a way, and for a lot of reasons why it's taken this long. But I think there's some exciting things happening, some promising things. All right. I'm waiting for the cue to. Are we?
We still have more questions, or
Okay.
we're getting close.
Anything else? There are other experts in the room, by the way, too.
What
She's hiding, but.
What do you hear about the Chinese are doing or the Japanese as far as mental health care?
You know, I don't know. I really don't know anything about Japan or China and their treatments. Not recent, anyway. Yes?
Can I do a quick plug? The Wellness Coalition is actually working right now on this stigma issue in the Ketchikan community, and part of the ways that we're doing this is through helping people tell their stories of resilience. And so we'll be conducting some writing workshops and some art workshops and things like that over the course of the next few months, and highlighting those in the community and allowing people that platform to share their story. Because one of the things that we found was that over, I think it was in Sweden, I believe, one of the few things that they found that Scotland. Was one of the things that actually changed stigma at a community level was highlighting stories who experienced mental illness to show that they could be people too. First. They're people first, and then they experience this. And so that's just my plug. If you guys want to get on board for, stomping out stigma in Ketchikan, we're working on it.
Awesome. I have a pen for you. Oh, what's this? Confront stigma.
Oh, I like it.
Yes.
Yes.
I've been waiting all day to give that to somebody.
Excellent.
Great. So Wellness Coalition is on it. That's awesome. So thank you very much for being here, being interested enough in this topic to come tonight. I really appreciate it. And thanks very much. Thanks for having me. Thanks for the library.